Thank you so much for that kind introduction, and thank you for the invitation to be here today. It's truly a pleasure to have the opportunity to be here in Armenia with all of you. As mentioned, Leo and I planned together that we'd kind of talk about the history, how we got to the present, and then segue to the concept of the PHITT trial and other rare cancers and the opportunity to collaborate. Because of these rare disease indications, it's really the best way we learn. So with that in mind, we'll talk about the PHITT trial to start. We'll touch on hepatocellular carcinoma because it's the first time we've been able to prospectively study that disease, which has been really, really wonderful given its rarity and poor prognosis. We'll talk a little bit about genomic features, what we know about these tumors and what we stand to learn going forward. I figured we'd touch on relapse disease for both entities and then other rare liver tumors and how we can use our collaborative infrastructure to address those as well. So as you all know, liver tumors exist at the very far end of the spectrum as part of the embryonal tumor category. They are about 1% to 2% of all solid tumors affecting pediatric patients, so very rare, but the perfect paradigm to study across countries, across continents, and an international forum. And I won't spend a lot of time here, but suffice it to say, we know hepatoblastoma is rare, but the incidence is increasing, as you heard. And there are some associations with germline predisposition and/or low birth weight being the highest relative risk. Hepatocellular carcinoma, on the other hand, tends to affect an older age population, is more rare, occurs in the absence of cirrhosis nearly 80% of the time in pediatric patients, and historically had correlated with Hep B vaccination rates in the sense that in sub-Saharan Africa, Southeast Asia, where Hep B vaccination rates lagged, incidence of HCC was actually rivaling that of hepatoblastoma. That trend has changed over time as Hep B vaccination rates have increased. But you can see from these SEER charts, of course, that hepatoblastoma tends to affect the younger age range, with HCC affecting the older age range. Again, symptoms are fairly similar between the two entities. Of course, you've got older children in the HCC category that can more adequately voice their symptoms. Thrombocytosis is seen in hepatoblastoma, given that these tumors secrete a TPO mimetic that drives up the platelet count. AFP is a sine qua non for disease in hepatoblastoma. We know all of these tumors secrete. Historically, we thought tumors less than 100, secreting a level less than 100, were a poor prognostic feature, when in reality, they were probably rhabdoid tumors and not true hepatoblastomas. HCC secretes AFP about 2/3 of the time, and we traditionally rely on the same imaging for both entities with the knowledge that if disease spreads, it's predominantly to the lung, in rare circumstances, bone or brain. So we'll talk about the PHITT trial, and you heard from Dr. Mascarenhas about the SHEIK initiative, and you heard about the risk stratification tool utilized for that purpose. Prior to initiation of the PHITT trial, there was also a lot of work put towards an international consensus for pathology, agreeing upon histology, immunohistochemical features, and what was known about genomic features, both for hepatoblastoma and HCC. This consensus group also coined the phrase hepatocellular neoplasm not otherwise specified to describe a tumor between hepatoblastoma and HCC, either with features of both or transitional or hybrid features, which tends to occur in older children, behaves more like HCC from a clinical perspective, and is harder to treat and cure. You already heard a bit about staging and the fact that in the US we had originally relied upon Evans surgical staging and now have transitioned to use of pretext as an imaging-based staging algorithm, which I won't go into in more detail given that Dr. Mascarenhas had talked about that in his talk. But this really sets the stage for how we think about how we would come together as a world to treat these tumors in the PHITT trial. And you also heard beautifully how we all kind of evolved. You heard about in bold, I wanted to highlight this before we get to the PHITT trial, but you heard about how in the US we incorporated use of doxorubicin for upfront unresectable patients, while our European colleagues eliminated doxorubicin for a subcohort of patients with standard risk disease, i.e. pretext 1 through 3 without annotation factors. Those patients don't totally overlap. There's a Venn diagram of overlap between those two. But when we think about who needs doxorubicin and who doesn't, we can't perfectly answer the question given that our risk stratification tools were not the same. And then, of course, our Japanese colleagues were also studying cisplatin and adriamycin, so very similar backbone. They had trialed ITEC salvage with inclusion of ifosfamide for high-risk patients that had poor responses up front, and also trialed autologous stem cell rescue for patients with metastases, neither of which improved overall outcomes. But coming from this condensed global history and all the details you heard prior to the PHITT trial was a bit of a leap, particularly since not everybody biopsied tumors up front, and in Europe, the goal was traditionally to give neoadjuvant chemotherapy as opposed to pursuing upfront resection. So that then brings us to the PHITT trial, which of course is a collaboration between the Children's Oncology Group, over 200 institutes in the US, Canada, and Australia, and New Zealand, JCCG, formerly called JPLT, or our Japanese colleagues, and all of SIOP, which now encompasses GPOH and our German colleagues. The goal here was to harmonize the international approach to the study of liver tumors, and as I mentioned, for the first time, to prospectively study hepatocellular carcinoma. That wasn't for lack of trying. Hepatocellular carcinoma was previously incorporated on hepatoblastoma trials, grouped all together, treated the same way, sadly with very poor outcomes. But this was the first time we knew we'd be powered to study it across the world, essentially. We wanted to genomically validate some signatures which had been previously published, and then the goal was to create a really robust biologic repository, which hadn't yet existed for these entities within individual consortia. So many of you may be familiar with the trial, and I tried to, for simplicity's sake, kind of distill down the goals. So if you see in blue and green on the far left, the goals there were to therapy reduce, on the far right was to therapy intensify, and in the brown or orange was to therapy optimize. So starting on the left, these are patients with completely resectable disease. Those with pure fetal histology are again observed to validate findings published previously by Dr. Malgolovkin and others. And for non-pure fetal, completely resected, the goal was to administer 2 cycles of cisplatin monotherapy. That was a therapy reduction from the prior COG approach, which were 2 cycles of cisplatin, 5-FU, and vincristine. If you look on the far right, those are patients with metastatic disease. The goal here was to validate the SIOP-4 findings. If you recall, that was a pilot study that only enrolled 30 patients, only a fraction of whom were metastatic, but published some of the best outcomes to date. So the goal here was to validate that induction regimen, and for patients who did not clear their lung metastases after the induction, the goal was to intensify further with inclusion of GemOx and sorafenib. And then if you look at the categories in between, to distill this down a bit too, in green or group B were pretexts 1 through 3 without annotation factors, i.e. easier to resect, possibly easier to treat. The goal here was to ask a surgical question, to ask who could be resected after 2 cycles of cisplatin monotherapy. And then for those patients, it was randomized to either 4 or 6 cycles, i.e. a therapy reduction compared to the historic SIOP-6 trial, which showed that 6 cycles was advantageous for outcomes. And then if you look at group C, or in orange, the goal here was a head-to-head comparison for patients with pretext 1 through 4 disease with annotation factors that were non-metastatic, with the goal to try and answer the question of who needs doxorubicin. Again, these patients aren't perfectly comparable to the former patients we treated in the US versus the patients that got cisplatin monotherapy in Europe, but it's our best ability to try and detect which patients do truly need doxorubicin and whether there is a superior regimen between the two. As I mentioned, the trial also, we were crusading for the study of hepatocellular carcinoma, knowing that the vast majority of these patients present in a very advanced state with very poor outcomes. We know that histologically disease is similar to that seen in adults, but only 20% arise in the context of cirrhosis, usually metabolic or structural, often not viral, certainly not alcoholic, I would hope. And so they're truly arising de novo in the context of a healthy liver. PDHCC responds better to chemotherapy than adult HCC up to 50% of the time, as reported on previous hepatoblastoma trials in which they were treated. And it's believed to be genomically distinct from disease arising in adults. And in fact, early studies here, you can see this was done out of Texas Children's Hospital. There was a small cohort of patients with PDHCC, and they compared in the right column to the most frequently reported genomic abnormalities in adult HCC. And you can see here that adult HCC tends to have CTNMB1 or beta-catenin mutations, whereas in PDHCC, they're more likely deletions. You can see here TERT promoter mutations as a maintenance of telomere length was pretty common in adult HCC, less common in PDHCC, but we know this is reported in that HCN-NOS category of transition. So we do see it in PDHCC tumors and HCC-NOS. And finally, again, perhaps more characteristic of HCN-NOS. And you can see here that TP53 is widely reported in the adult literature, but not in the pediatric literature to the same extent. What was called out in the PD patients, however, was again deletions of CTNMB1, MAP kinase or MEK-ERK pathway aberrations, and copy number loss. So again, small cohort, and these are the early studies, but clearly genomically different from adults. And then we know there's an entity called fibrolamellar carcinoma, and these historically had been grouped all together with conventional HCC, and we know they're not the same tumors. They're a unique entity. They occur in a completely normal liver. They're characterized by a DNA JB1 protein kinase A fusion, which all the tumors have, although it's been now seen to be shared with some cholangiocarcinomas in adults and in pancreatic tumors. There's no agreed upon systemic approach to therapy. Surgery is crucial. And there's a poor chemotherapeutic response rate with poor outcomes. And we're just starting to learn more about the immune microenvironment, as there's been a few case reports of excellent response to dual checkpoint inhibition in these patients. For the purposes of the PHITT trial, these were grouped together with conventional HCC, recognizing that they're different, but recognizing that it was the really good opportunity to learn from them prospectively. And so you see here, this is the HCC algorithm for the trial, again, color coding it to therapy reduce versus validate or intensify. So on the left-hand side, these are completely resected patients. There isn't an agreed upon staging algorithm for pediatric HCC. We don't adopt a lot of the adult staging algorithms, nor do we know whether pretext is validated for these patients. So we sought to compare either resected to non-resected, knowing that the chances of surviving if resected were much higher. For patients with disease arising in the context of cirrhosis, we opted to observe those patients per anecdotally what many folks had been doing in the US, but also what we know our adult colleagues do. And for patients with de novo disease, upfront resected, the goal was to validate use of Plato in the adjuvant setting, which had been utilized in the intergroup study with outcomes over 80%. For patients with metastatic disease, which we all know fare quite poorly, the goal was to compare in a randomization Plato plus sorafenib, which had been reported in the German literature to show some impressive, at least reduction in size of tumors, not necessarily increase in resection rates, or to intensify with use of GemOx sorafenib in combination. So we'll touch briefly on genomic features. We know that these are very quiet tumors, unfortunately. You've probably seen this figure multiple times, but hepatoblastoma is on the far left of the spectrum, which means that the somatic mutation rate is extraordinarily low. For PDHCC, perhaps it's a little different. It's a bit higher, but again, historically there hasn't been much in the way of somatic alteration, which begs the question as to whether epigenetics play a larger role here. These tumors likely exist on a spectrum, and this is taken from a publication by Pavel Sumasin and others at Texas Children's, which I think is really beautiful in that it shows that there's likely a hepatic stem cell, and that patients that progress along a more fetal algorithm have very few somatic mutations. Those that are more fetal embryonal or transitioning towards that HCNNOS tend to have TP53, TERT promoter, ARID1A, more aggressive genomic features that portend a poor outcome. And then there's probably a sidetrack that goes to hepatocellular carcinoma, and whether these patients exist on a spectrum. This was kind of one of the first insights that perhaps they do. As I mentioned, Wnt beta-catenin is really a hallmark of disease. 90% plus patients have a Wnt beta-catenin abnormality, whether it's a point mutation, small deletion, large deletion, et cetera. And we showed that the deletion rates for CTNNB1 are higher in the PDHCC population. We also know that aberrations in beta-catenin basically cause a destabilization of the degradation complex for beta-catenin, which then allows it to shuttle to the nucleus and affect transcription translation. So we know that that's an important pathway there. There have been many prognostic signatures that have been reported in the past, and on the left you can see work by Stefano Cairo and others in Europe, wherein 2 genomic signatures based on expression profiling have been reported, C1 and C2 as a phenotype. C2 does much worse and tends to have vascular invasion and metastatic disease as clinical hallmarks, whereas C1 was a much blander phenotype. Work was also done at Texas Children's looking, and I should mention that all the work on the left-hand side was done in post-treated specimens. And so do we really know how to think about those? We know that the morphology changes, the histology changes, and can you trust genomics on post-treated samples, or do the more aggressive features survive in the post-treated specimen, and is it therefore reliable? The work was done again, or similar work was done looking at the same expression profiling on pre-treated samples by our colleagues at Texas Children's, and they essentially showed 3 phenotypes, one of which overlapped pretty consistently with the C2 phenotype that was previously reported. But these were on small patient samples, so need to be validated. And finally, work done by our Japanese colleagues, which is really beautiful, looked at methylation profiling, trying to get at the epigenetic signature in combination with somatic genomic profiling and RNA expression profiling. And then what they essentially stated, much like that earlier publication did, is that these diseases probably do exist on a spectrum, that self-renewal capacity probably wanes over time, and that as these tumors either generate more somatic aberration and or occur in an older age range, they probably trend towards HCNNOS or HCC. But again, much more work needs to be done. So where do we go from here? Well, there are a couple pilot studies we're working on in the Children's Oncology Group, one for high-risk hepatoblastoma with the goal to study ototoxicity and the incorporation of STS in higher-risk patients. We know it's approved only for the standard-risk patients at present. Our colleagues in Europe, and we're working with our colleagues in Japan on this, our colleagues in Europe are asking a slightly different therapeutic question, with the goal is that we can proceed in parallel such that when we both result, we're ready to come back together for PHITT-2 in our next international collaboration. We're running a pilot for fibromyalgia carcinoma through the Early Phase Clinical Trial Network, and there's a lot of interest in studying survivorship because historically, liver tumors were not included in the childhood cancer survivor study run out of St. Jude, and so there's a lot to be learned about overall survival outside of just cardiotoxicity and ototoxicity for these patients. And of course, the goal is to come together for PHITT-2, and the question there is, will ototoxicity be used across the board? Can we use a genomic risk stratification tool? Or can we enhance the stratification tool we're using currently, perhaps simplify it a bit, it's very complicated, and or include genomics as a second pass or a later stratification algorithm. I'll touch briefly on relapse because not much is known about it, unfortunately. There are very few publications and the data is pretty broad. You can see this one publication that references the SIOP literature and patients enrolled on SIOP 1 through 3. This is for hepatoblastoma. The incidence was quoted as anywhere from 6 to 50%. It's really hard to get your head around where in that range relapse really exists. I'm comparing that data to data from AHEP 0731, the recently concluded COG trial, and I think what we can conclude is obviously patients with higher risk disease are at far higher risk of relapse, and when they do relapse, they're much harder to salvage, and that salvage rates are still only about a third of patients, unfortunately. So we need to do better, and we need to do a better job of sourcing data on relapse. And relapse HCC, gosh, we know is quite horrible. And despite all the advances in adult HCC and or the study, those agents don't tend to translate well to pediatrics in terms of efficacy. And even in adults, it's months of survival, which in pediatrics we're not really satisfied with. We know there are some successes in patients who haven't previously received doxorubicin. It's a good drug. And we're learning that for patients who previously responded to cisplatin, reintroduction is actually a reasonable option. Granted, there's a lot of end-organ toxicity concerns. We know that ifosfamide works quite well in combination with carboplatin and etoposide, and that irinotecan, while studied in the upfront setting, known to be efficacious, is also quite efficacious in the relapse setting, either in combination with other drugs, as a maintenance therapy, et cetera. But there's been a ton of disappointments, and there have been some really beautiful articles by Angela Trobolatario looking at all of the other drugs that have been trialed and or published. And I've listed out the disappointments there, unfortunately, and or areas wherein there is a paucity of data. But the issue with targeted therapies is that, generally speaking, pediatric patients with liver tumors are enrolled in basket trials, so there's only 1 or 2 enrolled. A lot of the times, there are not liquid formularies for these patients, so it's inapplicable for a younger age population. Some of the trials for which we had the largest numbers did not show efficacy. So here we struggle. And born from that was the RELIVE registry. And so we came together at one of the SIOP meetings in the SIOP Europe and said, how can we better source data on what people are actually doing, what isn't actually published? So 50 institutions from across 4 continents came together, with the global PI being Mark Ansari, and then there are individual chairs per continent. So I chaired the US-Canada chapter of this initiative. And the goal is to source data from over 200 patients. We're already at 250, as it turns out. But the goal is to reliably try to collect data to see what agents have been utilized, what agents are reported to have worked. Granted, we can't get the granular data we want with regards to imaging studies, but at least we can get an understanding of what people are using and what has been deemed to work in contemporary patient relapse. There are a lot of novel therapies that are on the horizon for patients with relapse disease, and this is kind of intended to be a broad overview. There is a trial out of Cincinnati looking at cisplatin reintroduction with the inclusion of HDAC inhibition for patients that were previously either cisplatin sensitive or not sensitive. There is use of tegavivint. Tegavivint binds TBL1, which stabilizes the beta-catenin destruction complex, and so interferes with the Wnt beta-catenin pathway that's open for patients across the board with a CTNMB1 mutated disease. Other targeted agents like Alaron 6924 is intended to interfere with TP53 and DNA damage repair, and has been shown preclinically to be perhaps relevant for hepatoblastoma. And there is an immunotherapy trial ongoing looking at codrituzumab. This is an antibody that binds to GPC3, which is a cell surface protein that is known to be expressed on all hepatoblastomas and HCC tumors, but not on healthy liver. So rare to find a target that's not on a healthy organ. For hepatoblastoma, HCN-NOS, and HCC, there are also a lot of options on the horizon. We're running a checkpoint inhibitor trial out of Boston with numerous sites that are likewise involved. We recently engaged with Eureka Therapeutics, which is an industry sponsor, to write a cellular therapies protocol intending to target AFP peptide bound to HLA-A2 using GPC3 as a co-stimulatory domain. We're starting as a dose finding with the goals to expand and include multiple sites throughout the US. Texas Children's runs a really beautiful program looking at an armored CAR T against GPC3, and again, that's both for HCN-NOS, HCC, and hepatoblastoma. And then there's a beautiful immunotherapy trial out of Johns Hopkins. That's a vaccine-based trial targeting DNA JB1 and the protein kinase fusion, in addition to dual checkpoint inhibition, that has shown some really nice responses in patients that otherwise don't respond. So how can we adapt this paradigm to the study of other rare liver tumors? Well, we know that there are other liver tumors, and they are indeed rare. And so for the purposes of the last few minutes, I'll focus on these three because they're primary tumors of the liver as opposed to metastases to the liver. I won't touch on rhabdomyosarcoma because it truly follows its own algorithm, part of the soft tissue sarcoma paradigm. But we'll talk a little bit about UESL. This is undifferentiated embryonal sarcoma of the liver. It's the third most common disease and accounts for about 2 to 15% of pediatric liver tumors, but again, rare. The median patient age is about 9 years. Sites of metastases include lung, but bone and brain are also potential sites, and there have been reports that brain is more common than we think, and perhaps we should be screening brain up front. It's the grand masquerader on histology. It can look like a lot of different things and or have rhabdoid characteristics. But it's postulated to arise from mesenchymal hamartomas, and imaging can be challenging because often you see remnants of the mesenchymal hamartoma with perhaps a rim of solid tissue. We know that the 1119 translocation is a diagnostic of disease and has been more recently testing positive in cases, but it can be a difficult diagnosis to make, particularly if you can't resect it up front and you need to find an area to biopsy. There have been multiple attempts to collect data on these rare patients, and so this was one quote-unquote large study, 25 patients. They received VAC, IFOS, and DOX. There were 8 partial responses. Our 0 resections were really what were correlating best with overall survival, but there were a few patients with R1 resections who still survived, and the overall survival was around 72%. The next cohort that looked at SEER database actually reported on 103 patients, but essentially with less granularity, given that the SEER database can be limiting. 5 patients underwent autologous orthotopic liver transplant and all survived. 100% survival was noted for patients if they were completely resected, and 91% if not completely resectable. Another series reported on 5 patients, all were resected up front, all lived. And again, I imagine you're capturing a theme here, which we'll kind of characterize in the next slide. But the last European trial looked at 65 patients. 25% received radiotherapy. Radiotherapy is a bit controversial for this disease because radiating the liver, as you can imagine, isn't always tolerated, but it generally reported on similar outcomes. So the take-homes for this rare disease, they were included on a prospective clinical trial through COG. There were 39 patients here. They had an excellent chemotherapeutic response, but unfortunately 6 recurred late, over 10 years out, and some to brain. So we know that the tail end of relapse for this disease is common. And a follow-up trial showed that perhaps pazopanib may influence degree of chemotherapeutic response, but that's not yet proven to affect long-term outcome. So the take-homes here is surgery is critical. Metastases certainly impair outcome, although there are some survivors with metastatic disease. Late relapses can definitely occur, and tumor can involve brain both upfront and then the relapse setting. And radiation is likely unnecessary if tumor can be completely resected, particularly to spare toxicity to the liver. Rhabdoid tumors of the liver, gosh, now we're really entering rare. And again, this is why there's such a paradigm for international study, because how else do we learn, apart from these case reports of 25 patients or so? The incidence is not even well documented due to the rarity. The median patient age is young, usually around 8 months. These can metastasize anywhere, as you might imagine, brain, soft tissues, other organs. And we know that these tumors are characterized by INI1 loss, and usually by SMARCB inactivation. And I had mentioned previous that we historically thought that hepatoblastomas with a low AFP were poorly prognostic, and we perhaps called some of them small cell undifferentiated, but we're recognizing now that the majority were INI1 loss and were probably rhabdoids. We know that there's the potential for germline SMARCB1 mutations, and certainly those patients present at an even earlier age and have much worse outcomes. But we know that the switch-SNF complex, which is involved in chromatin remodeling, is really crucial to these tumors and how they behave. I think one of the largest series was published again by Angela Trober-Lotario that looked at 34 patients over 40 years in the literature. So only 34 patients, one a year essentially or less. There were only 4 long-term survivors here. 2 of them had localized disease. I think the others were fortunate to have survived. And I think the predominant use of VDC and ICE chemotherapy is what most of us attempt to use, I think, without there being great study of this disease. And we know that there's very aggressive therapy in rhabdoids of the brain, with autologous stem cell rescue, which we haven't used in the liver, and of the kidneys with high-dose cyclophosphamide, but in truth, these patients are hard to salvage. We know that EZH2 can play a particular role, and that has been shown in vitro studies to be potentially useful in patients with aberrations in the switch-SNF complex and in SMARCB1 mutations. And this is in clinical trial, but sadly for relapse refractory disease, hasn't really moved the needle in terms of survival. And there was a recent publication in Clinical Cancer Research that looked at the genomic and immunologic characterization of INI1 deficient tumors, and that you can see that those with a SMARCB1 mutation had high expression of PD-L1 and more of a intensified CD8 infiltrate. And on the basis of that, there are now 2 trials, one of which looks at dual checkpoint inhibition in relapse refractory rhabdoid tumors, which include liver, and a second of which actually is including tazemetostat with dual checkpoint inhibition, with the goal of combining what we know to be good agents, neither of which have worked perfectly in isolation. And finally, angiosarcoma, very rare. We're just charting down the rare categories. Traditionally, patients are young, but not always. Usually, these tumors are extremely locally aggressive and infiltrative. They often include the entire liver, but they can spread anywhere. They're thought to potentially transition from benign hemangiomas, although I'm not sure the pathophysiology is completely understood, and the genomics are not perfectly characterized, but I show a picture here of just the extreme nature of how these tumors grow to include the entire liver. The calcifications are kind of, inclusive of blood. You can see the H&E is very challenging diagnosis to make because if the needle kind of misses the epithelium, you see blood pools, and so you often need multiple biopsies. But they do stain for CD31, which is an endothelial cell marker, and sometimes for GLUT1, which is reminiscent of the hemangioma from which they perhaps arose. There isn't great chemotherapy. Taxols are often used, kind of drawing from the adult literature in angiosarcoma. Orthotopic liver transplantation has been successful for some patients. And more recently, there was an interesting there was one patient who had a Notch1 ROS1 translocation, which arguably can be targeted by entrectinib or other ROS1 inhibitors. So this has not been reproducibly found in other angiosarcomas, but the question is, have we looked? I mean, I think with the pace of genomics changing, I imagine we haven't tested all of these tumors. So the takeaways are collaborative approaches are certainly warranted in such rare disease. I think the PHITT trial is really a model of collaboration across the world, and it's really beautiful that we're at a juncture where we're proceeding along different paths for our pilot studies with the goal of coming right back together. And I think we've all agreed to do that, and I think are excited to continue the collaboration. And my hope is that we'll learn a tremendous amount from biology, because that's really at the heart of these diseases, whether they're on a spectrum, and perhaps whether any are targetable, or whether we can risk stratify as a result. So with that, I'd like to thank everybody at my own institute who have been so wonderful in terms of our Liver Tumor Center of Excellence. I'd like to thank those in the Children's Oncology Group. Marcia Malagolofkin is the vice chair of that committee with me, the prior chairs of the committee. The PHITT trial is run by Greg Tiao and Jim Geller out of Cincinnati. And then there are subspecialty chairs because, as you can imagine, it's a big lift. And there are PIs, of course, in Europe and PIs in Japan. I want to thank the entire committee through COG, our international collaborators, and of course, our patients and families, without whom we could never study these rare diseases. So I'm happy to take questions.